Female urethral catheterization. Introduction. Female urethral catheterization, the insertion of a catheter through the urethra into the urinary bladder to permit drainage of urine, is a fundamental skill for the practicing healthcare professional. A balloon inflated at the catheter's distal end prevents it from slipping out of the bladder after insertion. An indwelling urinary catheter should be inserted only when absolutely necessary because its use is associated with an increased risk of developing a urinary tract infection, with the risk increasing with each day of use. Catheter-associated urinary tract infection, CAUTI, is the most common type of healthcare-associated infection. Use sterile technique when inserting, manipulating, and maintaining the catheter. Indications for female urinary catheterization. Urinary retention. Retention of urine can be caused by mechanical urethral obstruction or neurological disorders affecting voiding. A urinary catheter allows bladder drainage. Monitoring urine output. In a number of different clinical conditions including shock and renal failure, is it desirable to accurately measure hourly urine output to calculate accurate fluid balance. Continued. Unable to void urine in the normal manner. Unconscious patients, patients undergoing operative procedures or those with particular injuries, for example, fractured neck of femur. Medication administration. Medications such as chemotherapy agents may require to be administered intravesical, via the bladder. Contraindications to catheterization. No consent from the patient. Urethral stricture. Blood at the urinary meatus following trauma. Urethral stricture is typically caused by scar tissue narrowing the urethral lumen and making passing a catheter difficult or even impossible. Blood at the urinary meatus in the presence of trauma suggests a possible urinary tract injury, and imaging must be conducted to establish the extent of any such injury before attempting catheterization. Pre-procedure. Obtain consent from the patient. Prepare equipment. Position the patient ensuring dignity. Obtain consent from the patient. Explain the indications for the procedure to the patient. Explain the procedure to the patient. Explain potential complications. Estimate how long the catheter will be required. Check for allergies, latex. Local anesthetic gel. Equipment. Prepackaged urethral catheterization kits are commercially available. A typical kit includes a water-absorbent underpad, a sterile fenestrated drape, sterile indwelling catheter, latex or silicone 10 to 22 French, average adult sizes are 16 to 18 French. Continued. Sterile gloves, preparation swabs, forceps, antiseptic solution. A 10 cubic centimeters syringe filled with lubricating jelly. A 10 cubic centimeters syringe filled with sterile water for balloon inflation, a pre-connected, closed Foley system, and a specimen container. Procedure. Gather the appropriate equipment. Use the smallest bore catheter possible that will support adequate urine drainage. Obtain the assistance of a coworker to help with patient positioning. Provide a light source, as needed. Make sure that sterile technique is maintained during insertion. Perform hand hygiene. Put on personal protective equipment as needed. Place the patient in the supine or lithotomy position with her knees bent and legs abducted to allow visualization of the urinary meatus. Alternatively, position the patient on her side in a knee chest position if she's unable to tolerate supine or lithotomy positioning. Place a fluid impermeable pad on the bed between the patient's legs and under her hips to avoid soiling the linens. Wash the patient's genital area with warm water and soap. Rinse and dry thoroughly. Separate the labia majora and labia minora as widely as possible with the thumb, middle, and index fingers of your non-dominant hand so you have a full view of the urinary meatus. Keep the labia well separated throughout the procedure so they don't obscure the urinary meatus or contaminate the area when it's cleaned. With your dominant hand, use a sterile, antiseptic swab or sterile, antiseptic soaked, cotton-tipped applicator to wipe from the meatus toward the anus in a downward stroke. Identify the urethral opening. An assistant may be required, and sometimes additional lighting may help. Clean the urethral meatus using a top-to-bottom approach, left labia, right labia, and urethral orifice. Use a new swab for each wipe and dispose into the waste bag. Once cleaning is completed, remove one pair of gloves and dispose of them. Insert the local anesthetic into the urethral meatus and leave for a short time to have effect. Place the sterile foil bowl between the patient's legs. Remove the catheter tip from the wrapper, being careful not to touch the catheter. Warn the patient that you are about to insert the catheter. Insert the catheter into the urethral meatus. Gently advance the catheter whilst simultaneously withdrawing the wrapper. The urine in the bowl can be tested using urinalysis and sent for bacteriological examination. If resistance is encountered on insertion, rotate the catheter or ask the patient to cough. Beware when inserting a catheter in patients with urinary retention that a large volume of urine can drain very quickly from the catheter. Attach the catheter to the urine drainage bag. Slowly inflate the balloon with 10 ml of sterile water. Ask the patient if there is any discomfort on inflation of the balloon. If the patient complains of discomfort, stop inflation immediately and reposition the catheter. Where hourly urine volume measurement is required, a urometer should be attached to the catheter. Explain to the patient that the procedure is completed and check on their comfort. Catheter documentation often requires a sticker from the catheter packaging to be attached. Urometers typically have hooks to attach to the patient's bed. For ambulant patients, the urine drainage bag can be attached to the patient's leg using straps. Complications of catheterization. Urinary tract infection. This is the most common complication. UTI can be caused by lack of sterile technique during catheter insertion or by prolonged catheter use. In high-risk patients, those with compromised immunity. Urethral trauma, use of incorrect equipment or anatomical variability can result in urethral trauma during catheterization. Any evidence of bleeding during catheterization should result in the procedure being abandoned. Nursing alert. Never inflate a balloon without first establishing urine flow, which confirms that the catheter is in the bladder. Hang the collection bag below the level of the patient's bladder to prevent urine reflux into the bladder, which can cause CAUTI. Secure the catheter using a catheter securement device. If a securement device isn't available, tape the catheter to the patient's abdomen or thigh to prevent pressure on the urethra.